Welcome to our osteoporosis presentation for healthcare providers based on the 2023 Osteoporosis Canada guidelines. To help frame our presentation, we will discuss Stephanie's story, which is similar to that of many patients we see in clinic. Stephanie is a 64-year-old woman who was diagnosed with osteoporosis based on bone mineral density tests that was ordered by her family physician due to her history of alcohol use disorder and a low BMI. Stephanie is wondering what are her options for medication that can help manage her condition. If you are a healthcare provider managing patients with osteoporosis and seeking guidance on medication management, then this presentation is for you. Here's an overview of the topics we'll discuss today. We'll start with a brief introduction, the decision to start treatment, what are the options, follow-up and reassessment, followed by some resources and key takeaways in a summary. To start, there is strong evidence that medications significantly reduce the fracture risk in people with osteoporosis. Osteoporosis Canada recommends medication management for postmenopausal women and men over 50 who are at increased risk of fracture in order to prevent fractures, emphasizing the importance of treatment. All patients should also receive proper counseling on nutrition and exercise to optimize bone health and prevent fractures. For more details on these topics, please refer to our dedicated presentations on nutrition and exercise. First, we'd like to share general recommendations that apply to all patients regardless of their fracture risk. The Osteoporosis Canada guidelines emphasize the importance of balance and muscle strengthening exercises at least twice per week. These types of exercises not only help preserve bone density, but also significantly reduce fall risk. Next, dietary intake plays a foundational role. We should encourage patients to eat foods rich in calcium and protein. Lastly, vitamin D supplementation is recommended with at least 400 international units daily. Here are some good practice statements. Before starting osteoporosis pharmacotherapy, it's important to rule out secondary causes and assess any potential limitations for the different treatment options. If there's any uncertainty around fracture risk or management, seek advice from an osteoporosis expert. The baseline recommended labs are also shown in a table here. Here's a busy slide on the secondary causes of osteoporosis, just for your reference, that can be grouped as drug-related, endocrine disorders, gastrointestinal and nutritional disorders, rheumatologic, genetic, and other disorders. To determine if an osteoporosis medication is needed, you must first identify patients for assessment, and the guidelines specifically focus on postmenopausal females and males aged greater than 50 years old. Next, you'll perform a clinical risk assessment aimed at identifying risk factors and signs of a vertebral fracture. Risk factors include previous fracture after age 40, parental hip fracture, and current smoking, just to list a few, and also signs of a possible vertebral fracture, which may include height loss, decreased rib to pelvis distance, and increased occiput to wall distance. The patient we described earlier had two risk factors, being alcohol use disorder and low BMI. The next step is determining your patient's fracture risk. You will order a bone mineral density test based on their age, risk factors, and fracture history, and then stratify their 10-year fracture risk using their bone mineral density test and the FRAX tool, which is now preferred over KROC. The patient we described earlier was 64 years old with two risk factors, and so met the criteria for bone mineral density assessment. Based on the algorithm from the previous slide, pharmacotherapy is recommended for two groups. First, people aged over 70 with a T-score less than 2.5 and or a FRAX score greater than 20, and people with prior hip or spine fractures with more than 2 fracture events. There's a less strong recommendation for treatment, and patient preference should be taken into account for those aged less than 70 with a T-score less than 2.5 and or FRAX between 15 and 20%. For individuals who meet the criteria for treatment, bisphosphonates are the first-line recommendation. Anabolic therapy is recommended, however, for those with a recent severe vertebral fracture or more than one vertebral fracture and a T-score less than -2.5. We will discuss in more detail about each of the treatment options later in this presentation. If the decision is made to start treatment with bisphosphonates, the recommended duration is 3 to 5 years with alendronate, risedronate, or zoledronic acid. after 6 years, risks of continuing treatment generally outweigh the benefits. For some women experiencing significant menopausal symptoms, hormone therapy may be considered as an alternative to address both osteoporosis and menopausal concerns. Now for a more detailed look at the bisphosphonates, route and dosing, potential adverse effects, contraindications, and cost. We'd like to highlight that generally, weekly dosing of alendronate or risedronate is first line. IV bisphosphonates can be given at infusion centers. The common side effects of oral bisphosphonates are esophageal and gastrointestinal intolerance and musculoskeletal discomfort. And for IV bisphosphonates, specifically zoledronic acid, patients may experience transient flu-like symptoms, hypocalcemia, and renal toxicity in the context of known kidney disease. The rare side effects of all bisphosphonates are atypical femoral fractures and osteonecrosis of the jaw. Contraindications are generally chronic kidney disease, with GFRs listed in this table, as well as hypocalcemia. Specific to the oral bisphosphonates are esophageal abnormalities and the inability to sit upright. Generally, IV bisphosphonates are more costly, but there is a limited use code. Bisphosphonates overall are highly effective at reducing fractures. Over 3 years, for every 1,000 people taking bisphosphonates compared to no treatment, we can expect 20 to 30 fewer spine fractures, 10 fewer fractures in other bones, and 3 fewer hip fractures. Here's an infographic from Osteoporosis Canada demonstrating that the benefits of bisphosphonates at a population level far outweigh the risks. Over the course of 5 years, out of 100,000 people on bisphosphonates, 2,500 will likely avoid a fracture, and only 25 may experience a serious side effect. For hormonal therapy, there are 2 main options, including menopausal hormone therapy and SERMs, like raloxifene. The common side effects of both are venous thromboembolism, cardiovascular disease, and stroke, and for specifically menopausal therapy is breast cancer, and for raloxifene are vasomotor symptoms and leg cramps. Likewise, the contraindications are many of the aforementioned conditions, with them listed on the table here. For individuals who qualify for treatment but can't take bisphosphonates, denosumab is an effective alternative. It's important to note that, once started, denosumab should be continued indefinitely. For patients at a very high fracture risk, such as those with very low bone mineral density, severe or multiple spine fractures, consultation with an osteoporosis expert is advised to consider anabolic therapy. As mentioned earlier, anabolic therapy is recommended for patients with recent severe or multiple vertebral fractures with a T-score less than -2.5. Some important details can be found here about denosumab. It's administered every 6 months, and it's generally well tolerated, but there are several important considerations. These include risks of hypocalcemia and skin reactions such as dermatitis, as well as musculoskeletal discomfort. Like bisphosphonates, denosumab carries rare but serious side effects such as atypical femoral fractures and osteonecrosis of the jaw. It's contraindicated in patients with hypocalcemia, and while there's no specific GFR cutoff, caution is advised for those with severe renal impairment. Additionally, it's a more expensive option compared to bisphosphonate therapy. It's important not to miss or delay denosumab injections, as doing so can lead to rapid bone loss and significantly increase the risk of vertebral fractures. Because of this risk, denosumab is generally not used as first-line treatment. When started, it's continued indefinitely. If discontinuation is necessary, transitioning to an IV bisphosphonate is recommended. For those who have received 5 or more doses and are at high fracture risk, referral to an osteoporosis specialist is advised for individualized transition planning. So when we're thinking about anabolic therapy for osteoporosis, there's 2 main options to know: teriparatide and romosozumab. First, teriparatide is given as a daily injection, and it's typically used for up to 2 years. On the other hand, romosozumab is dosed monthly, and it's used for a shorter duration of only 12 months. The adverse effects of these 2 medications are quite different. With teriparatide, you may see things like orthostatic hypotension, nausea, hypercalcemia, hypercalciuria, and some musculoskeletal discomfort. Romosozumab, in contrast, carries more cardiovascular concerns, there's a higher risk of myocardial infarction, hypocalcemia, and again some musculoskeletal pain. One important distinction, however, is that teriparatide does not carry the risk of atypical femoral fractures or osteonecrosis of the jaw. So in patients who have experienced these complications with anti-resorptive agents, teriparatide could be considered as a transition option. Now in terms of the contraindications, teriparatide should be avoided in patients with severe chronic kidney disease, with a GFR less than 30, bone malignancy, hypercalcemia, or unexplained elevated ALP. For romosozumab, it's used with caution in people with severe renal impairment, a history of myocardial infarction or stroke, or hypocalcemia. It's worth noting that both of these therapies are costly, which can be an important factor in decision-making. Specifically right now in Ontario, romosozumab can be accessed through an exceptional access program for those at high risk and treatment-naive patients. Meanwhile, teriparatide is available as a limited-use medication, primarily for patients who have had complications like atypical femoral fractures or osteonecrosis of the jaw. Now for some key facts about anabolic therapy. First, it may be more effective in patients who are treatment naive, so it's important to consider early in the course for the right patients. In women who are at higher risk of fractures, for example, those with a recent severe vertebral fracture or multiple vertebral fractures along with a T-score of less than -2.5, there's high certainty evidence that anabolic therapy leads to greater fracture risk reduction compared to bisphosphonates. And importantly, after completing a course of anabolic therapy, it's recommended to transition to an anti-resorptive agent to help maintain the gains in bone mineral density. Once therapy is initiated, bone mineral density should be reassessed within 3 years or sooner if there's a concern for secondary osteoporosis, a new fracture, or risk factors for rapid bone loss. It's worth noting that for those who have completed a course of bisphosphonate therapy but have an inadequate response or substantial concern for fracture, consider switching treatment, evaluating for secondary causes, and consulting an osteoporosis specialist. If a patient isn't started on pharmacotherapy either because it's not indicated or they decline treatment, then the follow-up timing depends on their 10-year fracture risk. If their risk is less than 10%, you can reassess in 5 to 10 years. If it's between 10 and 15%, plan to reassess in 5 years. And if the risk is 15% or higher, they should be reassessed in 3 years. Once therapy is stopped, a 3-year drug holiday is recommended for standard risk patients with reassessment of their fracture risk afterwards. Higher risk patients and those with new fractures should be reassessed sooner. Here's a link to the Osteoporosis Canada treatments page for additional information. And we wanted to leave you with 6 key takeaways to help guide your approach to osteoporosis management. First, start by identifying the at-risk population. This is the foundation for everything that follows. Second, perform a clinical risk assessment to determine whether a bone mineral density test is needed. Third, use tools like FRAX along with the bone mineral density results and the patient's age to estimate the fracture risk and guide treatment decisions. Fourth, bisphosphonates are generally first-line therapy for patients who meet the criteria for treatment. Fifth, denosumab could be considered a good alternative for those patients who have contraindications, barriers, or intolerance to bisphosphonates. And sixth, consider anabolic therapy, especially in those who are treatment naive and have had recent severe vertebral fractures or multiple fractures. In conclusion, identifying and managing skeletal fragility helps reduce fractures and preserve mobility, independence, and quality of life for Canadians.